My name is Susanna. I'm a postdoc in the Bhatia Lab, and I'll be giving this hot topic on algorithm fairness and artificial intelligence for medicine and healthcare. And as Agita mentioned, we talked about this in our DI Journal Club, and we're excited to share it with the rest of you all. All right, there we go. Cool. So predictive analytic tools have really transformed our daily lives. So you'll see a lot of icons on here that you're probably familiar with using in every day. And what you might or might not realize is these tools use a lot of algorithms to figure out maybe where you want to go, maybe what you want to watch, who you should connect with. And they're really, really powerful, and then they have changed our lives. But something important to consider is that these technologies do have their limitations. And it's important to consider what happens when they're wrong. Let's say Netflix suggests you might like this show, you watch it, you end up not liking it. Okay, no harm, no foul, right? But what happens when that applies to someone's livelihood, someone's health, someone's life? It's more important in those cases that these AI algorithms are really, really careful and rigid. And so, as you're probably not surprised, algorithms and AI are making our decisions easier in medicine and healthcare, but it's important to consider at what cost. So like I said, they're increasing in everyday medicine, but there's really no regulation as of now to detect any kind of harmful biases in these tools. And a lot of the details about how the algorithms are made or how the AI is being applied are unknown to clinicians and the public. And there's really not a lot of transparency or regulation in this avenue. And so there's a possibility that these technologies could threaten to worsen biases in medicine. Since we know that right now there are biases present, we want to make sure we don't perpetuate that with algorithms or AI. So today, I just want to talk about a few different case studies that show that there can be biases in medical devices or in algorithms that are used in medicine and healthcare. And in particular, I'm going to focus on a few case studies on racial bias. And so first, I'll talk about two examples in medical devices, and then I'll move to algorithms. The first example I want to talk about is racial bias in pulse oximeter devices. So these are devices that measure oxygen saturation, and they became really well known and well used during the COVID-19 pandemic. However, there was a study that came out in 2020 that reinvestigated and also confirmed that these pulse oximeters had racial bias in their measurements. And this was kind of an idea that was known to some people in the field, but not to everyone, especially not to all clinicians. And in this study, what they looked at was they just compared the oxygen saturation, which is here on the x-axis, determined by a pulse oximeter, to the actual arterial oxygen saturation on the y-axis, which is a more accurate method, but more invasive, harder to do kind of at a point of care aspect. And they compared the levels from the pulse oximeter from white and Black patients. And you can see for a given oxygen saturation from the pulse oximeter, the average arterial oxygen saturation for Black patients was always lower than that of white patients. And that's because when these devices were made, they were mainly tested on lighter or white patient skin versus dark patient skin. And this led to Black patients being 3 times as likely to develop hypoxemia when using these pulse oximeters, and therefore worse health outcomes. And what's interesting, like I said, this information was actually known back into 1970s, but these devices were still sold and used due to their low cost. And so it really motivates the fact that there needs to be more regulation for these kinds of medical devices. On a similar note, there's also been found to have racial bias in temporal thermometers. So these are thermometers that can take your temperature by just using infrared light on your forehead. And similarly, in this case, there was a study in 2022 that found a difference in temporal versus oral thermometer temperature for Black patients, while there was no difference for white patients. And this led to 23% of fevers being undetected in Black patients. And so in this study, again, they did a similar idea where they looked at temperature using temporal versus oral thermometer at different cutoffs, and you can see that there are a number of more temperatures determined by oral thermometers and these temporal thermometers. And similar to the previous example, this was because these types of medical devices were only tested on certain populations and not a diverse set of populations. So now I'll talk about a few case studies for algorithm development and how these algorithms were biased in certain ways. And there's kind of interesting differences between these few examples and how they were racially biased. This first one I'll talk about was an algorithm developed back in 2018 to that was created to determine hours of aid that disabled residents needed in Arkansas. And once this algorithm was implemented, it actually suggested that there be large cuts of in-house care hours for disabled residents. And in this case, actually, this algorithm is not racially biased, but has a different kind of bias within its system. This led to poor health outcomes and more hospitalizations for people who were using this algorithm, who were under the care of in-house care. And it was found that these errors were actually just embedded in the algorithm itself. And again, there was no kind of checks on this algorithm to make sure that it wouldn't cause any terrible health outcomes. But instead, it gave these inappropriate cuts that led to these poor health outcomes. Another example of an algorithm is this VBAC algorithm that was developed to estimate the success of vaginal birth after a previous C-section in women. And it's actually been implemented for a long time amongst clinicians, but what was determined back in 2019 in the study is that it was highly dependent on race. And it was known that race was used as an input for this algorithm. But when they looked specifically at race, it said that Hispanic and Black women had a lower chance of VBACs, of vaginal birth after C-section, compared to white women, despite no biological relevance. And you can see on this chart here on the left, if they looked at BMI, which was an input for the success of this VBAC surgery, you could see that for the same BMI, white women had a higher percentage over Black and Hispanic women for basically no reason except false pretenses that have been incorporated into this algorithm. Another thing that was interesting to know is that this dependence on race was actually not obvious to clinicians. So they were applying this algorithm, but they didn't know that it was actually racially biased, and they were using it to make these clinical decisions. So in the end, this led to less Black and Hispanic women attempting these vaginal births, which is largely preferred over C-section because it can produce more complications and thus worse health outcomes for different racial populations. And this last algorithm I want to share with you all is actually very interesting because it doesn't use race, but as an input into their algorithm, but it was found to still be racially biased. So this algorithm in particular, and this was all reported in a study in 2019 in Science, it was used to determine whether or not a patient should enter a high-risk health program. And again, like I said, race was not a factor, but it still contained racial bias. If you look at this chart here, patients, all their information is inputted on, and the output is this algorithm risk score on the x-axis. And when the people in the study compared what someone's risk score compared to their number of active chronic conditions, which is another measure of how sick someone should be, or how sick someone is, they saw this huge gap between white and Black patients. So that meant for the same risk score, you would imagine that they would be the same level of sick, but actually Black patients were more sick than white patients for that certain risk score. And so the authors in this study wanted to understand why this was, how could it be racially biased without actually inputting race into the algorithm? And upon further analysis, they determined that the main factor biasing this algorithm was healthcare costs. And when they looked at this, at the same level of health or kind of health status, Black patients generated $1,800 less per year in healthcare costs compared to white patients. And this is just because of medical racism being entrenched into the health system. And so this is what this chart on the left-hand shows, where for a certain kind of level of chronic illnesses, you can see the mean total medical expenditure is lower for Black patients than white patients. And so it's kind of an interesting case where this algorithm tried to be unbiased with race by not including it, but actually, because they weren't taking account of that, this led the algorithm to be biased because it was not accounting for racial bias in the medical system. So I hope I've convinced you all that there's these biases present in medical devices and algorithms. but it doesn't have to be this way. What can happen to change this? And I think one important thing to think about is that it's important to have regulation of these devices and algorithms. So like I mentioned previously, there's kind of a lack of transparency on how these algorithms are made and what data is used to develop them. This is something that is sometimes reported, but it doesn't have to be standardized. And in particular, the FDA is kind of in charge of this kind of regulation process. And so while some medical devices are regulated by the FDA, although we could argue that there needs to be somewhat of an improvement on that matter, other algorithmic decision-making tools, like I've talked about, are not required to be reviewed or regulated by the FDA. And it's kind of interesting to compare that to drug regulation, which involves, share data publicly, a review panel to approve it. There's basically no regulation of these AI algorithmic tools. So you might be wondering what's happening at MIT. Is anything being done about this problem? And there's a few things that people are currently working on. One is done by the MIT Lab, where they came out with this initiative to evaluate technology on an international level and allow it to be fair, especially in terms of machine learning. And in addition, there's at MIT CSAIL, there was an article that came out where they're trying to inject fairness into the machine learning model. So they're making machine learning models, and they know that it's being trained on biased data, but they can kind of tweak it in a way where they can still make an unbiased machine learning algorithm by using this biased data. So there's kind of work being done, and I'm sure there's more examples than these, but these are just a few. And so lastly, you all might be wondering, well, I don't actually work on algorithms. How can this apply to me? How does this affect our research? And also, what role can we play to improve this process? Well, for those working on medical devices, it's important, again, to test your devices on a diverse set of racial populations to make sure it can work for everyone. And I think another really important detail is actually ensuring diversity in our cancer database populations. This could be MHC haplotypes that you're looking at. This could be using TCGA for cancer information, using cell lines, et cetera. And there's a really great paper out there that shows the difference in the kind of data we had based on cell line models, biobanking, genomics in terms of the racial populations represented in that data compared to the actual racial makeup of the world. And you can see kind of a large difference. There's a huge overrepresentation of white populations in these databases compared to our world. So this is something important to keep in mind. Another is to educate and advocate for diversity in clinical trials. Again, this paper also showed the difference in racial makeup in clinical trials versus the human population. And I think this is important, especially for developing therapies. And lastly, just understanding how algorithms that you might use were made, tested, and validated. And again, advocating for this on a large scale for not only research, but other types of algorithms as well. And with that, I think algorithms and AI are super important for the future. They're going to, change the way we do things, make us more efficient, make us more creative, but we need to make sure that they make a better future for everyone. And with that, I'm happy to take any questions or thoughts or comments. Thank you.